There is a trend that in recent examinations, at least 2 to 3 questions are asked from this upper limb in orthopedics, the traumatic events in the upper limb from the orthopedics. 2 to 3 questions in every pattern or in every examination they are asking. All right. Actually, the most commonly asked question are from the nerve injuries, and after that is the upper limb trauma. So that is the reason why upper limb trauma is very important. And before we talk about the fractures in particular, we are going to have a slight discussion of the relevant anatomy related to the upper limb trauma as well as the soft tissue injuries. All right. So before even we talk about the anatomical aspect, there is a sample question for you, or this is the sample question for you, that which of the following is a dynamic stabilizer of the shoulder. So by this point you already came to know about that stability of the shoulder joint is the function of two stabilizers, two sort of stabilizers. One is a set of dynamic, other is the set of static stabilizers. All right. Before we talk about the stabilizing factors of the shoulder, why stability of the shoulder is very important? Because shoulder joint is made up of, just look at this image. Shoulder joint primarily is made up of the glenoid and the head of the humerus. Although this is all anatomy, you just have to listen and correlate. No question is directly going to be asked out of what we are discussing right now. But the importance of this topic or discussing this topic is important, so that you understand that what is the reason for this pathological mechanism. So if you look, primarily the shoulder joint is made up of the glenoid and head of the humerus. Now glenoid and head of the humerus, the articulation is known as ball and socket type of the joint. So this is a kind of the joint which is called by the name of ball and socket type of a joint. But head of the humerus could be acting as a ball, but the glenoid is not acting as a socket because it is not effectively congruent to keep the entire head of the humerus within its surfaces. Rather, it is just the 25% is the contact surface area of the glenoid with the head of the humerus. So that means it is not a stable kind of the joint. Additional stability is required in order to make this joint stable, because this is the most mobile joint of the human body. So additional stability is provided by these static and dynamic stabilizers. All right. So if you divide the stabilizers of the shoulder joint, one is a set of static, other one is just a set of dynamic stabilizers. Static means they are immobile structures which are holding the shoulder joint within its congruence. So one is glenohumeral articulation itself. As I told you, the two bony surfaces actually are responsible for 25% of the articulation in between the two. Second is the presence of ligaments. All the ligaments which are present around the shoulder joint, like glenohumeral ligament, coracoacromial ligament. So these are the ligaments which are immobile, are responsible for maintaining the congruency or stability at the level of the shoulder joint. But the most important one is the labrum, glenoid labrum. Now, what you should know about glenoid labrum? First of all, just try to understand by looking at this image. Imagine this to be a glenoid, which is a bone. Over to that, there is a fibrocartilaginous structure attached to the glenoid bone. Imagine this is the glenoid, the bone. Now, over to that, there is a fibrocartilaginous structure like this. Now, what is the function of this glenoid labrum, or what you should know about glenoid labrum? That it increases the contact surface area by further 50%. As I told you, that glenohumeral articulation was 25%. Now, there is a provision by nature of the glenoid labrum, a fibrocartilaginous structure onto the glenoid bone, which is increasing the contact surface area by further 50%. That means combining both glenoid bone as well as labrum, now the head of the humerus is having 32.5% articulation. All right. So that is one point. Second is, it also increases, this glenoid labrum is also responsible for increasing the concavity at joint. It is also responsible for increasing the concavity of the joint. That means it is also responsible for increasing the suctioning effect on the head of the humerus to get it pulled within the glenoid labrum. All right. If you look at this, this is relatively flat structure. Here, the bone is relatively flat, but the glenoid labrum is relatively more concave, as a result of which it is providing a suctioning effect to the head of the humerus, thereby imparting or adding stability to the shoulder joint. Hopefully, you have understood every of the static stabilizers. Next are dynamic stabilizers. Dynamic means during the movement, they are responsible for stabilizing the shoulder. All right. One of the dynamic stabilizer is a deltoid muscle. Deltoid is a more or less a lateral muscle which is having three of its components. That means anterior, dead lateral, and posterior. But its main function is abduction. And once you abduct the shoulder, the deltoid gets contracted, thereby buttressing the head of the humerus or pushing the head of the humerus into the glenoid cavity. All right. So one deltoid during activity is responsible for imparting the stability to the shoulder. Another one is the biceps pectoralis. That means all the muscles which are arranged around the shoulder, anterior, lateral, and posterior to the shoulder. But more importantly, or most important, is the rotator cuff. And all of you are aware that rotator cuff is a common blend of four tendons, that is supraspinatus, infraspinatus, teres minor, and subscapularis. Alright, so this is what we are going to have a discussion on. As far as the soft tissue injuries or the pain to the shoulder joint is concerned, majority of them, or almost 90% of them, are because of injuries to the rotator cuff. Alright, from the anatomical standpoint, you already are aware that rotator cuff is a common tendinous insertion of four tendons: supraspinatus, infraspinatus, teres minor, and subscapularis. Now, where exactly this supraspinatus is located? This is how the rotator cuff looks like. Now, if you look at this, anteriorly we are having subscapularis. That means subscapularis, because it is present anteriorly, it is responsible for internal rotation. So, it is responsible for internal rotation of the shoulder. Now, both the teres minor as well as infraspinatus, infraspinatus as well as teres minor, both of them are present posteriorly, and both of them are external rotators of the shoulder. So, they are responsible for external rotation. And finally, the superior one is supraspinatus. So, supraspinatus is the superior tendon, superior to the shoulder, and it is responsible for initiation of abduction of the shoulder. So, it is responsible for abduction of shoulder. Isolated abduction is the function of the supraspinatus from 0 to 15 degree. Then it will assist in abduction. Hopefully, you have understood that how these rotator cuffs are arranged, or the muscles of the muscular component of the rotator cuff is arranged around the shoulder. The anterior is subscapularis, posterior is the teres minor and infraspinatus, and superiorly we are having supraspinatus. Now, let's get back to the anatomical perspective of the same again. So, these are the muscles which are arranged around the shoulder joint. This is all anatomy that you have to remember. Now, as far as this rotator cuff is concerned, we already came to know that supraspinatus is responsible for abduction, infraspinatus as well as teres minor for external rotation, and you came to know why. And finally, subscapularis is responsible for medial or internal rotation of the shoulder. Now, it is also very important to have a basic understanding of at least two nerves around the upper limb, because the two nerves which are closely associated with the bone are axillary nerve. You see, every time there is a fracture in the proximal part of the humerus, every time there is a dislocation of the shoulder, every time there is a fracture in the neck of humerus, head of humerus, or neck-head interface, axillary nerve is likely to get injured. And second is the radial nerve. The radial is the nerve which is lying across the shaft of the humerus. It is very likely that if there is a fracture in the mid 1/3 shaft of the humerus, then radial nerve could get impinged. And examiner is asking this question again and again, that if there is a fracture in the mid 1/3 of the humerus, what is the name of the nerve injured? Or they can give you a clinical picture that the patient is having fracture, he is having inability to extend the wrist, there is a loss of sensation over the first dorsal web space of hand. What is the diagnosis? Alright. So, this is one set. Similarly, with the dislocation of the shoulder, they are asking what is the name of the nerve injured. With the fracture of the proximal humerus, they are asking the name of the nerve injured. With the management of the proximal humerus fracture, they are asking the name of the nerve injured. So, the name of the nerve which is very closely associated with the anatomical neck of the humerus is axillary nerve. So hopefully you have understood the two nerves which are important in relation or in context to the this anatomy of the bone. Next, now before we come to the soft tissue injuries around the shoulder joint or pain around the shoulder or the reasons for the pain around the shoulder, there are several sample questions. Like the question number 1, 23-year-old male came to OPD with the complaint of right shoulder pain. All right, there is pain in right shoulder, but now this is a key clinical finding they are mentioning, that there is an anterior tenderness was present which got relieved with the arm in flexion. Now, when you examine the patient with the extended arm, there will be a tenderness over here anteriorly, but it got relieved when it is kept in anteriorly. When the arm is held in flexion, the tenderness got relieved. What is the most probable diagnosis? And you will be provided with these 4 same options every time. Adhesive capsulitis, all right, calcific tendinitis, then painful arc syndrome, all right, all these complications are always going to be there. Options are always going to be there. Similarly, another question, that a 53-year-old male came to OPD with the complaints of occasional pain and weakness in the left shoulder. So there is pain associated with the weakness. Asking for active abduction. Now this is a core clinical sign which is mentioned in the question, which you will identify after some duration of time, is indicative of, is actually diagnostic for that particular question, for condition. All right. Active abduction, patient was not able to do so. That means when you are asking a patient to abduct the shoulder, he is not able to do so. When he was able to, but what you did then, that you passively abducted the arm to 90 degree and then you asked the patient to abduct it further, the patient was able to do so. Alright. So when you ask a patient to initiate the abduction actively by himself, he won't be able to lift it in abduction. But when you ask him to do it after 90 degree of abduction, he manages to abduct it beyond 90 degree. So this is what they are asking. What is the most probable diagnosis for that? Alright. So these are the sample questions provided to you. And now we are going to have a discussion on the rotator cuff disorders. You know, primarily the rotator cuff disorders can simply be divided into 2 or 3 components. But you know, the disorders are, it could be a rotator cuff syndrome where there could be a subacute tendinitis, chronic tendinitis. Then there could be a calcific tendinitis, and most importantly, there could be an adhesive capsulitis. Now, adhesive capsulitis, here itself we are going to cover this topic. That is adhesive capsulitis or a frozen shoulder. This condition is also known by the name of periarthritis of the shoulder. Alright, this is also called as periarthritis of the shoulder. Now, every time you get this question in your examination, every time, they will always mention the age, which is middle age to elderly. That means not a young individual, obviously. And it will always be associated with a diabetes mellitus. So imagine an orthopedic question. You are confronted with the orthopedic question where elderly age is mentioned, history of diabetes is mentioned, and the patient is not able to abduct and internally rotate the arm. These are the 2 findings of frozen shoulder or adhesive capsulitis. That means there is limitation of abduction and internal rotation of the arm. Alright. So this is confirmatory that the patient is suffering from frozen shoulder. This finding is confirmatory. So these are the 3 points always for this frozen shoulder related question or periarthritis related question. 1, elderly. Second is history of diabetes. And the third one is confirmatory finding, that is limitation of abduction and internal rotation. Alright. Once you make the diagnosis, you know, in around 11 to 15 months, the situation is self-resolving. Alright. If you don't treat the condition, it will become normal after some duration of time. But that duration is too long. That means 11 to 15 months is a long duration. No one is going to ask you about the management though, but it is a kind of a condition which is spontaneous, which recovers spontaneously. This is what you have to remember. And this is all what has been written over here.